Hey everyone, it's Jamie Batts. This is A&P2. We're continuing with our respiratory physiology lecture. We just finished talking about the hemoglobin oxygen saturation curve, and now we're going to continue with this topic. Just switching here. That's where we left off, and talk about carbon dioxide. We were just talking about oxygen in the blood and some factors that affect how oxygen and hemoglobin will dissociate. Let's talk about what happens to carbon dioxide in the blood. It's actually a little different than what you might think. There's actually three fates for carbon dioxide when it enters the blood. First of all, let's understand that all of our peripheral tissues are producing carbon dioxide as they are metabolizing. It's a natural byproduct of metabolism. So as our tissues are producing carbon dioxide, it's going to diffuse into the blood at the periphery, and it's going to do one of three things. It can dissolve in the plasma. It just dissolves right into the mix, just like, sugar in your coffee. Has a very limited solubility, just like oxygen, so it doesn't dissolve very readily. It's not the preferred method. A small percentage does that. A larger percentage is actually going to bind to hemoglobin. Did you know that? So our oxygen is not only bound to hemoglobin, but carbon dioxide can also bind to hemoglobin. It forms a molecule called carbaminohemoglobin, HbCO2. It's reversibly attached, just like oxygen, so it can pop on and pop off as needed. The majority of our carbon dioxide in our blood is converted to something called carbonic acid. This happens in the red blood cell. So our carbon dioxide, when it enters the blood, some of it will dissolve. The majority of it goes into our red blood cell. Some of it on the red blood cell will bind to hemoglobin and become carbaminohemoglobin. The majority of it is converted into carbonic acid. We'll look at how that happens. So converting carbon dioxide into carbonic acid, H2CO3, uses an enzyme called carbonic anhydrase. Carbonic anhydrase is present in all of our red blood cells. It's present in a lot of cells, and it's all over our body. The reaction is very simple. It mixes carbon dioxide and water and gives us carbonic acid, right? H2O plus CO2 can give us H2CO3. However, H2CO3 is a fairly unstable acid. It's a weak acid, actually, so it will dissociate. H2CO3 dissociates into bicarbonate, which is HCO3, and a hydrogen ion. That second hydrogen ion will pop off of carbonic acid and form a bicarbonate. So the bicarbonate, HCO3, is going to be pushed out of our red blood cell. As it's pushed out of our red blood cell, chloride is going to be pumped in. So there's an exchange. It's called the chloride shift. This reaction goes on. Carbon dioxide forms carbonic acid dissociates into bicarbonate and a hydrogen ion. The bicarbonate is pushed out into the blood in exchange for a chloride ion. Now the chloride ion is inside the cell. Guess what? Our hydrogen, that leftover hydrogen ion, is actually going to bind to hemoglobin. Hemoglobin is acting as a buffer in this case. It's soaking up the extra hydrogen ions, because what are hydrogen ions? Right? Hydrogen ions are the concentration of hydrogen ions is what gives us an acid. So if our hemoglobin is there to soak up the extra hydrogen ions from the dissociation of carbonic acid, hemoglobin is acting as a buffer. Buffers are there to help balance the pH. Guess what? If your blood pH gets a little too high, our hemoglobin can dissociate from that hydrogen ion, release the hydrogen ion into the blood to help lower the pH, and vice versa, right? So hemoglobin is there to help act as a buffer. So here's the whole kit and caboodle when it comes to how carbon dioxide acts in the blood. Small percentage dissolves. The majority of it goes into the red blood cells. Some of it binds to hemoglobin, forms carbaminohemoglobin. Majority of it's converted by carbonic anhydrase into carbonic acid. Carbonic acid dissociates, forms a bicarbonate. Bicarbonate will be released into the blood. The hydrogen ion sticks around. That bicarbonate was shifted or exchanged for a chloride ion, and our hemoglobin soaks up that extra hydrogen ion. I would, if I were you, create a graphic organizer of this. Fate of carbon dioxide in the blood. You have your 3 little stems coming off of it. Explain them, write out the equation for forming carbonic acid and bicarbonate, and make sure that you draw arrows to show the fate of bicarbonate and chloride, as well as the hydrogen ion from the dissociation of carbonic acid. This is the whole thing in step-by-step process. So, why is all of this important? Well, it's super important because our respiratory gases have to be maintained in equilibrium. The partial pressures of oxygen and carbon dioxide are very stable within the alveoli and in our body tissues. What is maintaining that is our blood. Our blood's going to take away the extra, either push it out or pull it back in, right? So the partial pressure of carbon dioxide and oxygen are very stable. Every oxygen molecule that's entering the peripheral tissues is going to be balanced by an oxygen molecule at the alveoli. It's an exchange. One exchange on the internal respiration for an exchange on the external respiration. If the equilibrium is disrupted, then our oxygen demands are not being met. So when the oxygen demand increases, our equilibrium becomes disrupted. And that's when our respiratory rate and our tidal volume are going to increase to meet those demands. Without that increase, the alveolar, the blood, and the tissue partial pressures of oxygen are going to drop. That's going to cause an increase in carbon dioxide levels, and that can lead to hypoxia. That can also lead to a drop in pH. You will see, and something that I should just address right now, it's super important to understand, there is a relationship between carbon dioxide levels and blood pH. All right, so carbon dioxide in our body acts like an acid. Why? Think about what we just described happens to carbon dioxide. Carbon dioxide, the majority of it, is turning into carbonic acid in our blood, right? So that carbonic acid is going to work to lower our blood pH. So the more carbon dioxide we have in our blood, the lower our pH will be. So if we have this super buildup of carbon dioxide, or our body's not getting rid of carbon dioxide the way it should be, our blood pH is going to drop. So here is the oxygen pickup and delivery system. That was a side note, but it's something that's super important to note because you're going to see that along the way. So oxygen pickup in our alveoli. Oxygen comes in, it can dissolve in the blood. Most of it goes onto the red blood cell, attaches to hemoglobin. We have oxyhemoglobin. Then it's going to go into our systemic capillaries. Oxyhemoglobin is going to dissociate. Dissolved oxygen is going to go into our peripheral cells. Then carbon dioxide is going to be exchanged. Our peripheral cells are going to get rid of the carbon dioxide that they just produced. Some of it's going to dissolve in the blood. Some of it's going to attach to hemoglobin, form carbamine hemoglobin. Some of it's going to be converted into carbonic acid, which will dissociate, release a bicarbonate ion into the blood solution, and hemoglobin will capture that extra hydrogen ion. At the lungs, the reverse is going to happen. All of these reactions are reversible. All of these reactions are reversible. So that bicarbonate comes back into the cell, chloride shifts back out into the blood. Bicarbonate and our hydrogen ion are going to form carbonic acid, which will break apart into water and carbon dioxide. The carbon dioxide is then released into the blood. Carbamine hemoglobin dissociates, carbon dioxide is released not into the blood, into the alveoli. That dissolved carbon dioxide that's in our blood is going to be released back into our alveoli. So all of those reactions are reversible. Here they are in a step-by-step process. What I suggest doing, putting these slides out individually and captioning them, explaining them, and maybe even using them to teach someone else about how this happens. It's a good sequence builder. This is a video, which I forgot to remove from the PowerPoint because it's not going to work in the PowerPoint like this because I didn't attach it. But you can go into Mastering AMP and you can watch this exchange video. You can also go into YouTube World and type in pulmonary gas exchange video, something like that, and you'll see a ton of these out there in the internet world. You can pause the video here, go back and review this section. We're going to keep going with this section and talk about lung compliance in pulmonary diseases. The compliance of the lungs is basically how easily our lungs expand and contract. This is influenced by the internal lung structures like the elasticity and the resilience. It's also influenced by our chest wall, how well our ribs move. If we have arthritic ribs or some type of bone or joint disorder, that the lung rib cage might not be able to expand as easily. So this can be taken in a static measurement to determine the interpulmonary pressure at different lung volumes to be able to see how great of a pressure differential your lungs can create. So the greater the compliance, the lower the tension on the walls of the lungs at any given volume. As you lose supporting tissues and destroy the alveoli just through old age and wear and tear, that's going to increase the compliance. In normal lung compliance, arthritis, other skeletal disorders that can cause a decrease or reducing the elasticity and resilience of your lungs. There's also respiratory distress syndrome that can be caused by inadequate surfactant production, and that can lead to a lung collapse. The lower the compliance, the greater the tension on the walls of the lungs, and therefore the harder it is for the air to be conducted through those passageways, because the pressure differential is not able to develop. There's also resistance in the lungs. This is the force that's required to inflate or decrease the lungs. This is involving the muscular activity during pulmonary ventilation. This is typically 3 to 5% of our resting energy demand. So if we have an increased resistance, you have more force that's required for breath. This is going to increase the energy demand needed for breathing. So in normal lung resistance, you have this kind of static, resiliency that's going on. But the higher the resistance, the harder it is for that air to pass along the conducting passageways. Things like bronchoconstriction can reduce the airways. The lower the resistance, the more easily that air will flow along the conducting passageways. Something like bronchodilation, reducing the resistance, allowing for that air to pass through. There's also COPD, chronic obstructive pulmonary disease. This is the general term for any progressive disorder of the causing the restriction of airflow. There's 3 examples. Asthma, asthmatic bronchitis, is an example of COPD. It's the term that's used when you have very acute or intermittent symptoms. It's characterized by having very sensitive airways. They become irritated easily. The response is constriction of that airway or increased mucus production and inflammation, right? It could be caused by allergies, toxins, or even be exercise induced. Taking an inhaler, right, to allow basically negating the effects of the bronchoconstriction, allowing for bronchodilation. There's chronic bronchitis. This is a long-term inflammation and swelling of that lining and the overproduction of mucus, clogging the airways, increasing resistance, producing frequent coughing, as well as lots of sputum or mucus being produced. Cigarette smoking causes this. It's the most common cause. There can also be other environmental irritants leading to this, as well as chronic bacterial infections leading to chronic bronchitis. Heart failure can result from this, causing widespread edema. Low oxygen levels, giving your skin a bluish tint because that oxygen is not perfusing through the lung tissue as needed. Swelling and bluish skin has led to the description that we call blue bloaters, people with chronic bronchitis who may appear very puffy and blue because they're not, their heart isn't pumping like it should, and their lungs are not perfusing as they should. So very sad. Emphysema is a chronic and progressive condition. It gets worse over time. This is where the alveoli gradually expand and they merge with other alveoli. So this forms a larger airspace, but it has less elastic recoil to it. So there's actually less respiratory surface for exchange. This is going to result in less oxygen absorption, which ultimately leads to shortness of breath in people with emphysema. There could have exaggerated respiratory movements, or they could even be required to wear or use oxygen, an oxygen tank. Heavy breathing, having a pink tint to them. These are called pink puffers in some cases, if they have that pink kind of puffy appearance. I'm not a big fan of calling people blue bloaters or pink puffers. I think medical terms should not be offensive. Those are a little inappropriate, in my opinion. Emphysema, you can see that lung obstructions of the lungs, all of that kind of white speckleness in there, not allowing that perfusion. I'm gonna, I think I'm gonna stop the video here. Trying to gauge how much more we had left of this lecture. So I'll stop the video here, and you can go back and review these few disorders as well as the other topics that we covered in this portion. See ya.